can we treat AI as just another form of image processing? Because I think we do have to do in hospitals fairly well. It probably makes it a little bit less intimidating if we consider things that way. So I'll go through kind of my argument for that. AI, typical workflow, something like this, I'm sure you know, you have an image, you pass it through some kind of black box, and it gives you a derived output. So maybe informed diagnosis or treatment or something else. Actually, this workflow is quite similar to other things we have in hospitals. I'll just show a few examples. So radiotherapy planning, for example, we take an image, a CT, we pass it through some software, and we do some quite complicated maths on those pixel intensity values to come up with a treatment plan. Now, that software may be a bit more manual, may be semi-automated, although AI itself is actually being used in treatment planning. But the overall process is quite similar to, if you get chest X-ray AI tool, in that, got DICOM data moving across here, and, we have to go through a commissioning process similar to AI. Another example, nuclear medicine, for many decades now, we've been taking images, passing them through software, and deriving metrics out at the end, like kidney function, that kind of thing. I can't with loads of these examples, to be honest, but another one, cardiac function assessment. Hospitals take MRI data, ultrasound, whatever it is, and they want to measure things like ejection fraction. So it's a similar kind of process. So hopefully you can kind of see that actually parts of the workflow, at least, you have some elements there that are kind of common to how an AI tool works. Other things we talked about today, image de-identification. That does happen to varying degrees of doing it well, I suppose, in hospitals already, particularly if you're doing research, things like clinical trials, you're doing research measurements, long and short axis on CT images. Those sort of things have been happening in hospitals for a long time. So, even if the technology isn't necessarily brilliant, people, it's an expected thing. And also existing skill sets. People often talk about the fact that AI training for medics is not very good, for allied health professionals, and I would agree with that. We're quite a long way behind. But if all you want to do is test an AI tool to see how well it works, I think we do have quite a lot of staff with the necessary skills. We're going to pick up clinical scientists, because I am one, and we don't really promote ourselves very well. But ourselves, radiographers as well, particularly those who work in PACS, I know some in the audience, we understand images, standards and governance associated with them. And just to kind of drive home the point, this is from the syllabus for teaching new medical analysis, which I do routinely. We have to understand all the kind of things we talked about already today. The DICOM image standard, technical nodes, information governance, modernization of data. So we were kind of born to do AI evaluation in a way. So maybe that's not very exciting. Hopefully you can appreciate we have some of the elements probably in our hospitals that can help us with AI evaluation. It's maybe more of an issue of identifying who those people are and kind of bringing them together. And that's kind of where our 3D lab comes in. So back in 2010, we set this up. The idea was to bring image processing together under one roof as much as possible in the hospital. Because it was being done disparately and to different levels of quality in different areas. And we just thought, following models in the US, actually, if you bring it together, you can do it in a more optimized, more efficient way, a more accurate way. So the kind of things that we do are quantitative imaging. So inside the hospital, we do all of the routine cardiac MR function stuff. So, drawing around left ventricle, cardiac MRs. We measure things like brain volumes over time. We do total kidney volume measurements on polycystic kidney disease patients. We do all of the tumor measurements for clinical trials. Our radiographers do this. Lots of other examples. Just all this kind of image processing stuff under one roof. Then in later years, we've got into 3D models. So again, it's just image processing. You're taking a data set, CT, MR, whatever, but in this case, you're making a 3D model. So it could be electronic, 3D printed, surgical planning, etc. But because we do all this image processing stuff, actually, we've got a lot of the infrastructure in place already, and it's possibly a good way to do AI evaluation. And I'll just kind of show you why that might be. So in terms of hardware or software, we have, good connections to RIS and PACS, and we're very used to downloading large data sets kind of automatically. We have dedicated storage. We have our own PACS, actually, which is less of a dumping ground than actual PACS. And we can store data on the internet and share it with other people in a secure way. And that's all just from the work we're already doing, nothing to do with AI. We also have software for image processing, labeling, normalization in the ways kind of Simon talked about, all these kind of intricacies. We did this quite a long time already anyway. So very applicable to AI evaluation. And I appreciate probably no one else in the audience had a similar issue to us inside their trust, but hopefully, if you have some thing that's happening in terms of image processing, there might be people behind that who can help you with AI evaluation. And luckily, with Foresight, when we started, we decided to set up a database of all our cases that come through, partly just so we could charge people for the work we were doing, actually. But it means that we have images and then associated with that metadata, like in this case, the recent case, so we've got long axis, short axis times that tells you where the lesion is, that kind of thing. But that's absolutely perfect for training out algorithms and benchmarking data sets, that kind of thing. So lots of the stuff is already there. Staffing, again, it's the kind of people that know about images. So we have 2 ultrasound radiographers, split between 12 who kind of rotate through and do lots of the kind of manual contouring where it's not necessarily had AI applied to it yet. 2 ultrasound equivalent scientists, including me, and obviously lots of input from radiologists and other clinicians. So, they're going to be the people that these tools are aimed at in lots of cases. They can come to us and say, we've got this tool we want to try. You've already got the kind of infrastructure there. And then won't talk too much about governance. Andy's already mentioned that. Got links to the research up this, and we have an information governance process. And something really important is funding. So we already have SLAs with other departments to do these quantitative image measurements, and things like RESIS come with a tariff, which I know is not huge, but there is some money there. So we have money to kind of maintain this infrastructure already. So AI is just kind of little addition on top of that. We're not setting up a whole new thing. Which maybe means we can be a bit more agile. We're not relying on things being the same. It doesn't matter if the whole landscape completely changes in 5 years. Again, just to hammer home the point, all the resources already in place for AI evaluation. So what I thought I'd do is show how having image processing expertise might be helpful for an AI evaluation project. And so I'm just going to go through a chest X-ray example we have. So like everyone else, we struggle to report chest X-rays in a timely manner. So on site on our chest X-ray, on our X-ray machines, we had an AI tool we wanted to try out, see how well it worked. So like everybody else, is it going to really help us? So we set up this little study design, which isn't too complicated really. We just wanted to look at load cases over time, see how well the AI works against the software works against the clinical report and the MDT diagnosis, in particular, whether there's cancer or not. So from a kind of high level, fairly straightforward. But what we wanted to do from the start was not just push through a load of cases where it was, yes, this one's normal, this one's abnormal. What our radiologists are very keen to do is actually say, okay, the abnormality is in this part of the image, or it's in this part of the image, and there's 2 areas to look at, not normal, or whatever. So you can kind of dig into how well that chest X-ray software is working. Because we have lots of software already for image processing, we're able to set up like an interface like this for our radiologists. They can come along and do blinded re-reporting of all those cases, which must have been really boring, and fixed answers. So they can select like image quality, the study classification, but also importantly, they can mark on the image where they think the abnormality is, and you can save that out later for further analysis. And then when the AI tool does the same thing, we can see, well, where do they line up and where don't they line up? So in this picture, the white circle is where the AI tool found an abnormality, the yellow and kind of magenta circle, which probably you can see, but where the radiologists thought the abnormalities were. So, in this case, they are lined up. But on the right-hand side, the AI missed it. If you just either, a binary abnormal or not, you wouldn't get this kind of information. And the reasons talked about earlier with stuff that comes out of AI vendors' software isn't always great in terms of adhering to standards on DICOM. So getting out things like the position of the AI tool where it thought the abnormality was is really quite a hard problem sometimes. So quite often burned in screen captures, so it can be very hard to do that kind of thing. But yeah, so this is all done behind the firewall, by the way, inside the trust, so you don't have to send it outside or whatever. And if anyone's interested, these are the kind of results, headline kind of thing. Sensitivity is good, but as other sorts, people have found specificity not quite so good. Lots of nodules found by the software, quite a lot fewer by the radiologists. So if we use this, we have a massive CT waiting list. Yeah, just gives you an idea of the kind of thing you can do if you understand a bit about image processing. Yeah, I've talked for a little while around various different things. May have been helpful, may not have been, but I'm going to end with a bit of summary now. I think it's useful to consider AI software as a form of image processing, or what I would call image processing, because this is something that does happen in hospitals to a greater or lesser degree. And there are staff and people who know how to do that, and possibly need to bring them together. And I think a centralized image processing lab can be a way to do AI evaluation, and it might be a little bit more sustainable way to do it, where you're not, waiting for the next charge of $100 to go on to test the chest X-ray or whatever. And I think if you can do image processing well, you can probably do AI evaluation too. Yeah, and that's about it. Thank you very much.